In a sense, it's easy because I have level connected trigingival margin. The worst would be to have same situation but with a recession, because then I will have to pull the soft tissue down. More difficult. Okay? So this case was we just placed a provisional restoration, and I take an impression to have an idea the diameter of the tooth. And this case is going to be deeper, so I will use transmucosal abutment. In this case, we're going to use the N1, which is the new implant. It's going to be very much studied on the DTF implant studio. I do my planning with Novel Active. So the N1 will go through the same ring that the 4.3 active. The problem with the N1, you should know that the longest implant is 15 millimeters. So this is a pity, because sometimes we want the longer implants, like 18. But in this case, I planted is not the depth that I would love to. I would love to have a minimum depth of 5 millimeters. So we'll go by hand and place the depth, which is average 5 millimeters. 2.5 for the transmucosal and another 2.5 for create the emergence profile for my soft tissue. Okay? I hope that is clear. This is the surgery. So I remove the provisional, I cut the root, I do vertical incision. In this case, I cut it in half. Then I rest on the adjacent tooth, and I don't touch the bone. So I pull the rest of the tooth. This is the conventional way. Okay, you can see the fracture all the way up, that goes all the way down. So we take all the granulation tissue, we de-epithelialize in order to have a nice bonding of my cervical circular connective tissue graft. We use diamond burrs, we use laser to remove all the soft tissue from the inside of the inside aspect of the palate. I clean, I purify. You can see everything is huge, large buccal defect. I de-epithelialize from the outside and the inside, so we'll have a faster re-epithelialization. And then I just use 2 burrs to place my implant. In this case, we place first the implant. Usually I like to, before I place the implant, always to place my buccal plate, my buccal membrane with osteobiol, my lamina soft. This is the typical why I like to do the buccal first, because then I'm not messing around and touching the implant. Here is not guided because N1 doesn't have a guided cylinder. This is the carrier, and then I will go 5 millimeters in depth from the trigingival margin. I forget about the bone. And here we did the bone, the elevation of the flap after implant placement. For me, it's not as convenient because you are disturbing the bone that has been packed in between the implant and the socket. But this is the membrane that is going to be tagged higher. I elevate full thickness flap with the bone. You can see here I moisture a little bit my membrane so I could place it where I want it. I make sure no tissue is interfering. tag my membrane. I prefer always to do the buccal plate and then close the space, but this is another way. So you can take whatever technique you want. I prefer always, as I said, first here we place the piece of tissue on the buccal aspect below the membrane, below the flap, and then we suture it on the buccal aspect of the flap and on the buccal aspect of the membrane. So far easy. So we reposition so it stays where we want it. Then I want to graft above to the head of my implant. This bone has been already with antibiotics. I placed my 2.5 millimeter transmucosal and I tied it to 30 newtons, I think. And then I packed my bone crystal to my transmucosal, always with the gas to control exactly. I take a little bit out of the cortical bone. I mark a little bit my chimney, and I go to the lab, I cut it, I place it back, I place a little bit of flowable composite so the particles of titanium doesn't go into my socket. Okay. And then I reline same provisional with the same emergence profile in the same place that it was. Okay. Then I remove everything, take it out. Here is my titanium abutment. And then I prepare my trouser for the 360 connective tissue graft around my tooth. The tooth is being screwed a little, so it moves, but it doesn't follow. And I place my connective tissue where I want it, and once I like it, I squeeze it. It's too much. You can see how the tissue goes around. So I'm going to create a little bit more space on my crown to allocate the soft tissue exactly where I want. So it's like a mushroom. It's as narrow as possible for me to be able to prosthetically guide my soft tissue to the prosthetics, not the other way around. Okay? So I move it where I want it. Once I like it, I screw it in. Make sure that everything is as sealed as possible. And suture. Okay? So this is where I started on the left. The middle 2 weeks, usually I wait 2 weeks before taking and this is 6 months. Okay? The more I have to re-entry, maybe the case, you can see that here the quality of the tissue is pretty much not too much keratinized tissue. We'll discuss that in the afternoon today. If I have to re-entry the same site because I need more soft tissue, I will wait 8 months before I get back, because what I want is to have to remember that all the bone that was reconstructed is coming from xenograft, and it takes 8 months for remineralization. Okay? So this is the day 0, how much I plugged it. You can see it here, how much bone. And this is the periapical X-rays. I almost hit the roots. You can see how much we fill the gap. And this is the try-in. Today we have the chance to have zirconia against the abutment, so we don't need the tie base, which gives a lot of problems for control of the value for the technician. You have to glue it. The biggest problem is how to, when you have a type base, how to control the value and transfer that information to your technician, your fusion. So it's not easy. This is where we started. This is the final result. Yoshi's work. You can see here the fistula, all the problems, and you can see how much bone interproximally we were able to level with the transmucosal, and the final result. And this notice the initial situation, the day 0, and then this is about a year after the placement under function, how it looks like. You can see the resorption, the bone. So let me show you another case. This is socket type 3. This is a 9 kilos tooth. This is the first case, one of the first cases I wanted to use the transmucosal. And it's a tissue recession, not only buccal, but also interproximal. And this is how we finish with the immediate implant placement in this situation. Okay, nice volume, nice papilla height. So whenever you are planning to place a deep implant, always you should be using a transmucosal because you are working at a different level. Okay? So you can be 3.5 millimeters away from the have two heights, 2.5, have 175, 2.5, and 3.5. Okay. So this is the N1. This is the situation. 1 kilos tooth. Difficult case, so you have many options here. She has huge tuberosities. So we are going to compensate everything with connective tissue graft. Okay? And you can see where I would love to have my 3 gingival graft compared to where my bone would be is about 8 millimeters. Okay? So from the 3 gingival margin to the bone is 8 millimeters, so that's why I would rather have a transmucosal abutment. So the type 3 alien can class 2. So you can see that we did a composite. You can see the internal resorption. She's in pain. Usually on the surgery I never take the bone inside because that tooth becomes bone. So this is the provisional I did before, and you can see very much the width. I take first the connective tissue, and you can see the huge tuberosities to compensate vertically as much as I can. Let me go through it. It's pretty much what you have seen before. So this is the day 0, this is 1 week, and this is 3 months later. It was too wide, we wanted to improve the situation, so we decided to do second connective tissue graft, to graft especially in the interproximal. So I remove as much as possible, make it as close as possible to the tooth, take the epithelium off, and then do a vertical connective tissue graft, horizontal connective tissue graft from tuberosity. At that time, Nobel didn't send me the transmucosal abutment. It came like 6 months later than what I wanted. So I had to use whatever I had, and you can see how much the tissue can be brought down. You can see how the tissue is being placed exactly what I want to promote the tissue to come down. And it's true that we need to pull that soft tissue Usually I put it in three ways, in the center and then in the line angles, just to bring the soft tissue towards the prosthetics. Okay? So we use the contact points to put it into the shape. This is what it looks like. This is from Gerardo Chacon, the reverse V, and it works beautiful. It's really simple, and this is the result. 3 months later, you can see if you don't graft on top of the implant, you will never have one. So it's a pity that I never was in the possibility of having the transmucosal to graft with bone, as you have seen before. So it's nice to see that. It is circum provisional. You can see there is no bone because I was not able to graft it above my implant head. So if you don't graft, you will never get the bone. And then we finish the case. Yoshi finished the case, and this is how it looks like. I did my transmucosal placement later on, like maybe 8 months later. You can see we have a beautiful result, but no bone. So this is a pity because we could have improved the situation in a better way. And I see the letters on the back, like soft tissue managing. Can you take it out? So let me show you another case where we use, here is a more difficult case because it's a recession. So the tooth has a recession. Yeah, can you take that out? Ah, it's very good. Perfect, thank you. So we have to do, we have to bring the tissue down, we have to bring the tissue down, we have to bring the tissue down and leveling. This is a crown that I made 20 years before, metal ceramic. So you can see that we need some sort of orthodontics in order to bring those teeth back and bring the tooth down. So this was a multidisciplinary approach. When I saw him, we did apicoectomies 10 years before, but he has a fistula. So the fistula is coming through here. We still have bone, thanks God. I always place a provisional, and with that provisional, we were planning to place, as the implant is going to be quite deep, because we're going to bring all the tissue down. So not only we have to control the buccal bone, but also the tissue in the lower position. So this is the surgery which I will go forward. So we extract the tooth. You can see the fracture on the tooth. No buccal bone at all. You can see the relationship of the bone with the interproximal is perfect. Only all buccal is gone. In this case, we're going to do connective tissue graft on the buccal, interproximal, because it's less than 10 millimeters from the fringe-gingival margin. We use laser. We clean it as much as we can. We place our N1. We pack the bone. We position it exactly where we thought it would be. You can see now the space. We want to fill it with bone. And we place our provisional abutment. We pack with bone all around. You can see how we level the soft tissue. We're going to do a buccal connective tissue and a circular connective tissue. In this case, I did connective tissue in all the teeth. So I elevate the flap. You will see papillas because the papillas were really narrow. So from the top, we were able to loosen the flap and doing a horizontal incision to your periosteum above the fornix to allocate and create more space for my connective tissue. So we did connective tissue around my abutment. Okay. And then we did a connective tissue in all the teeth. This is something that you have never probably seen. That's why I want to show it to you. I want to anchor that soft tissue that is coming from the palate to the interproximals. So, and then I will add another piece on the crown. Okay. So in this case, we use Emdogain from Straumann. We etch the roots with ETA. We suture the tissue on the crown. We did the same on the buccal, on the implant to compensate the recession. And then we fix the horizontal bone. Okay? And then what we want is to fix it to interproximally to the palate. Okay? When I fix it, the interproximal is going to be fixed from the palate. So we come with a suture. You'll see it in a moment. Let's see. I come from the palatal aspect, go from the base of the papilla outside on my flap, and then take interproximally my connective tissue in the middle of my soft tissue, and coming back and fix it to the palatal papilla. So the connective tissue is fixed horizontally, vertically on the buccal aspect. I'm going to fix to the interproximal palatally, as you can see here. So the tissue is sticking out of the scallop. And I do the same in every single papilla. I try to see where I want my soft tissue to be horizontally. And once I have fixed it, the connective tissue will sticking out. Will be sticking out of the flap as you see it. And now what you do is you cut a little bit, and then you slide it underneath the buccal aspect. Okay? So you will have a double layer of connective tissue, especially when you have a really thin biotype like this guy. So you are just moving it underneath your connective tissue, so you have a thicker tissue, okay, connected. So basically what you do is you are doubling your soft tissue, you are cutting away. You can see how many connective tissues this implant has. Okay? Okay? So that tissue will be supported by the crown. And you can see it's totally, will remove the buccal contour of my provisional in order to allocate the tissue exactly to where I want it. So a lot of prosthetic work too. And then we suture everything as you have seen so far. We are bringing it coronally. We do our contact points. then basically we just pull our tissue. Depends if you want the full papilla. You go below the contact point and you suture. So traction of the flap is really important. If you have the mobility of the flap and you just use your contact point as a lever arm type 1, then the suture will break. If you go around the contact point, you don't know how much pressure you are creating to your flap. And this is the problem from using the contact point as too much of a pressure. Here, you only go once above the contact point. So in this case, if you don't want to touch the palatal bone, you go below the contact point and only take the buccal tissue, for example. So it depends what you want. You go over the palatal papilla. You can see here, I only take the buccal flap. I go and place my finger to see where is the tissue, and I bring everything. And just the soft tissue and the flap. So you can do whatever you want. You can take both, or you can take one, or you can take everything. You can see how easily the tissue is coming down. Really easy. Taking everything, placing the finger, line angles, to pull the tissue exactly to meet the emergence profile of the tooth. Okay? We do that for every single tooth, and this is the situation. Day of the surgery, 2 weeks. Okay, of course now the tissue is going to be, as you all know, you have to pull the flap at least 2 millimeters from where you would love to have it. Please notice where is the bone located. We brought quite a lot of bone coronally, and this is the final result with the final abutment, final crown. Where we started, where we finished. Final result here, the bone state didn't resorb as much. I don't know why some resorbs and others doesn't, but this is the iPhone video of the final result. Okay, let me show you what is the problem you might face. Because at the beginning, Nobel, the N1, did have this universal tie base, which has to be glued to the crown. The problem is, if you glue this into the crown, even though this is in gold, it will affect the value of the restoration. So it's difficult to try it. Usually we glue with cyanoacrylate just for trying and just for occlusion and contact points, and I would like to share with you how we do it. This is a class 2 case, so we have a recession here, and we're going to place an implant that is a little bit deeper, and we use the transmucosal. The problem of using transmucosal is also the tooth. The narrower, the smaller the tooth, the more difficult it is to pack the bone in between the root and the implant, because the implant becomes bigger, the part becomes too big. And I would like to share also, in this case, the problematic of a huge class 2 with no contacts and having a crown that I need to sprint to the other teeth so this guy doesn't move. going to have a recession here, an implant here, and then from here we're going to splint all the way up to the canine. Okay? So this is the planning, and this is what we did. We placed the implant, we placed our transmucosal, we did the connective tissue all around, and we did the connective tissue on the adjacent tooth also. Okay? So this is the surgery, but I will go forward. So I will place my transmucosal, blah blah blah, my bone. I will elevate my soft tissue, and what I want to do is I will bring down the soft tissue, place my connective tissue around my crown, and do also the recession of the canine. Okay, so you can see how I'm modifying and tailoring in front of you with the video. The space, the smaller the space, the more you have to be careful the way that you tailor the tissue. Maybe you have to remove it because it's too much. So you have to go to a stage where the soft tissue gets in and is not coming out. You can see all the little steps we need to perform in order to get to a situation where I can place you can see all the space that we allow for the connective tissue to be entrapped. Okay. Until it totally disappears. When I move the flap, whoop, and everything is disappeared. Okay? So you can see the connective tissue is just around my crown, my functional crown. And then what I'm going to do is I'm going to pull all the connective tissue down. I'm going to graft my canine on the buccal aspect with a sling suture. And then what I'm going to do is I'm going to pull the Ronco. It's a French periodontist. It's a great suture. You go to the line angles, and then you go below the contact point. You cross in front, of the verticals, and you go from front to back and you suture. So for me, this is an amazing one shot. You bring the tissue down and against the tooth. Really efficient. You will see it in the next tooth. My connective tissue has not been really perfectly adapted, but you can see how much it's like an age. This guy has a book of quintessence. It's called tunnelization. I learned this from him, and it's a great. So you go from line angle from line angle to line angle. And then you go from back to front. You cross over from front to back, and then you pull the tissue down and bring it against. So it's a great, really nice. So you can see when the patient leaves, is the healing, the top, bottom, 2 weeks. So the problem now I have to is the ring. I have to create the pressure on the lab. And now I have to, how do I splint the crown to the rest of the teeth? Okay. So usually we do something in zirconia all the way up to the incisal edge, and we only do layering of the porcelain on the buccal aspect. Problem is when you use this type of metal connection, it becomes the tooth becomes gray. If you bond, it's difficult to take it out. So we use a cyanoacrylate to glue it in order for us to see the value. We know that it's grayish. Usually, Yoshi, what it does, it makes opaque layer of white porcelain inside the crown. So we can opaque this grayishness of the tie base. So here is the try-in, we adjust the occlusion, and then you can see how dark is the tooth. So we take pictures of everything in order to bypass the problems of the underneath substructures, either the tooth and the tie base, which is not easy to do. So we use stone models. It's done by Yoshi, beautiful work. And then what I ask him is to make a hole. So if I make a trough on the tooth is never enough because it debonds. So what we do is we make a trough, a hole, so the wire will go through the crown. So even if it's debonded, the wire will maintain the crown and won't extrude. Okay? So we go through all the universal base cement. We like the multi-unit hybrid cement, which is the whitest you can find on the market. And we have to bond it once we like the color. You can see the little. You can see the. I'm sorry. You can see the layering of opaque white layering of ceramics in order to opaque the dark structure. We do the same for the implant. So we do the try-in. You can see the wire goes through the hole, and then we use this thing that is called the silver plug. This is a polymer that is embedded with silver. And what it does is, as soon as the bacteria touches the silver, it dies. So this is from Italy. I don't have any royalties, but it really helps a lot to avoid bacteria into the chamber. In Europe, this is becoming more and more important. We don't use cotton, we use Teflon, but this is much better than Teflon. So we cut it and put this composite on top, and the results are just really nice. So you can see that we have a hole, and in that hole we will put the 0.18 wire. You can see the beautiful tissue around. And it's the situation, class 2 patient, coronal wire splinting the crown with the rest of the teeth with a little hole. So just a few ideas. So you can see the situation and the bone and the stability of the volume of the tissue, the proximally and locally of the N1 case. Where we started, where we finished. Okay? Where we started, where we finished, and ready for meeting. is the most difficult one. Lower anterior teeth. She is a judge in my office, difficult. And in those cases, I use a single unit. I use the smallest. I don't use the multi-unit because they are way too big for lower anterior teeth. So I use the tie base, and then I use abutments, which I make a bridge and make some holes. So I'll show you the case. Not an easy one. So the plan here is to extract the tooth, reconstruct and see if I can improve the bone interproximally. It was closer to a bridge rather than implants on bridges, but I decided it's a provisional restoration, so I decided to place 2 implants here. Difficult one here, another one here. The bone regeneration was good. So you can see how much work it was done. So I placed the 2 N1s. Why N1? Because it's much narrower, the prosthesis, than the active ones, and for lower anterior implant, the bone is really hard, really dense, so you need to be careful. This was done freehand. I place my 2 implants. I will place my transmucosal. I will first pack my bone in what is left from the socket and the diameter of my implant, which is almost nothing. Then I will pack leveled to my transmucosal, which is almost really difficult. I torque it, and once I have done this, I will do my provisional. Reline the same provisional on the same that I have into my titanium abutments, protect the socket, reline my provisional, then allow the space for grafting. I will make some incisions to elevate. I will cut the muscle horizontally so it's not pulling my flap, and then elevate crestally and elevate lingually. Actually, the elevation over lower flap is much easier because you can elevate from the buccal and from the palatal. So I go above the muscle, I cut the muscle on the base horizontally in order to elevate all the soft tissue. I go lingually and try to elevate with the periosteum. Bring all the soft tissue that you have seen and suture it crestally. So I bring it with my finger where it should belong, which is on the crest. Okay. I position. I have one pull here, one pull in the palatal, one pull in the palatal. So I have already centered horizontally. Then I make my incisions. Usually today I use laser to find my access to my implant, and then position my flap and pull the tissue up as you have seen before, and bring all the tissue to a more coronal position. Okay. So this looks like day 0, the video you have seen. This is 2 weeks, but this is 3 months. I have lost verticality. So I decided 3 months later to go back and do a second round of connective tissue graft on the same side, and this is 2 weeks after. Okay? The problem now is this is 3 months later. I wait between surgeries 3 months, but I don't have gingiva, so I decided to do a free gingival graft. This free gingival graft is coming from the side, on the posterior side, so I have the same color, and then this is the results 3 months later. Okay. So these some some pictures 8 months later with the final crown and abutment. So here we did single abutments, screw retain into the implants, and then a bridge that is perforated on the palatal aspect, so to bypass a little bit the problems and come up with a 3-unit bridge where we have 1 implant, 1 pontic, 1 implant, natural tooth, natural tooth, natural tooth, composite, composite, composite. Okay. Bleaching is iPhone video. So you can see where we started, where we finish. Implant, pontic, implant, natural tooth. I would love to talk briefly from posterior. I don't have too much to tell you about anterior. And on the posterior today, I'm just using a lot of on-ones because I can gain bone vertically. So I would like to share with you some ideas. This is old cases. Not necessarily I place my implant on the center of both roots. Sometimes I place, what I like is to place my implant where I have the biggest bone walls, okay? And I have a defect here in the mesial aspect, and usually I feel it. I want always to have my implant flush. If I use transmucosal, I place my implant 5 millimeters from the gingival margin. But here this is how we used to do. Today I always use a transmucosal abutment because I gain a lot of verticality. Okay? So this was mixed with hyaluronic acid, and I place a gas. This gas is going to be the space for my connective tissue. So if you want to have a perfect, beautiful posterior implant, do a connective tissue. This is rubber composite, nothing new. So you have done this since the 90s. And this is the space for my connective tissue. So I polish, and then I take my connective tissue and I will graft it crestally. If you don't graft on the posterior, you know that you will get a resorption of 1 millimeter vertically, 2 millimeter collapse. Okay? It's normal. But if you graft, you will have almost no collapse. Beautiful. So you can suture it if you want into position. So the connective tissue doesn't move once you place your hin abutment. And the connective tissue has to disappear. Okay? It looks like nothing was placed. You see there. You can place hyaluronic acid. You can punch your flap. It really makes a big difference. But it's not really necessary. But if you use it, you will see the difference. Okay? Everything adds. It's not the panacea, but and usually sometimes what I use is cyanoacrylate. This is for creating a stability of the flap so food doesn't get in. And I use cyanoacrylate from the supermarket. Okay? Not the periacryl which costs a fortune. So this is what it looks like. This is a full contour crown. and you can see the bone. So today I place, this is the beauty of the hyaluronic acid. It attracts and stabilizes the blood. This is where we started, and this is where we finished. You can see the bond defect here. But usually today I place a deeper implant. I will have a transmucosal, and I have much better results bone-wise. Okay. Let me jump on this one. Let me show you where I like to use it the most. Another one is a posterior implant. If you don't do anything, well, you maybe have a chance. This is the palatal root, this is the medial root. You can see I'm trying to plan an implant on the palatal root. There is nothing. Okay. So I place my palatal implant 5 millimeters away from the pregingival margin. And then I place bone all around. And you can see this is where we started. The sinus is there. How I like to do it is, here is the bigger defect is here compared to the median. So usually when I have a big defect, I hope you can try to follow me. And I want to show you how I do it. I place my implant 5 millimeter in depth. Then I place, of course you need to have the stability of your implant above 35 newtons. Then I fill my bone with antibiotics, and then I fill the bone up to my implant head. Then I place my transmucosal. Remember, this transmucosal you cannot compensate for angulation, so it has to be in a certain way in the middle of the occlusal table. Then I fill my Krios or xenograft material up level to my transmucosal. Okay. Yes? So far so good? Yes? Okay. And now I'm going to place my titanium abutment, my prosthetic part. Before I place my titanium, I put some composite, flowable composite on my titanium, and I dry it. Then I place my titanium with a little bit of composite, flowable composite. And then what I do is I pack BIOS above my titanium abutment all the way up to my fringival margin. So I bring all the way up my xenograft material. And then what I do is I take composite and cover the socket. I don't remove anymore my healing abutment, customized healing abutment, and I polish chair side. I polish, in the mouth. So I don't remove it. Whenever I have a bone defect, I always go against the teeth. So I protect the papilla. Okay. So this is 2 months. You will have bone resorption, but the resorption is pretty much leveled. No connective tissue graft. They took the impression. If you do connective tissue graft, it will be much better. But I want to show you, and today there is really solid research showing you that if you only use xenograft material, you will have soft tissue collapse. So this is the dual, how you call it, dual effect. This doesn't really work, but sometimes this is where we started. Sorry. I want to show you the collapse. is where we started, bone loss. This ambulation is the day of 0, and this is pretty much, we are not up here, so we gain some millimeters, okay, especially on the bone side. But it's okay for just, you can see the collapse of the soft tissue. Thanks God we had a recession on the posterior. And we put a crown, full contour crown, with a decent result, with not much difficulties. Another one, palatal root, implant placement. You pack the bone. This is the molar. Nice result. We have plenty of them. It's difficult to shoot a video. You can see here, if we do delay this sinus lift, today it can be traumatic. So basically you will see here the different steps. We place bone all the way up to the implant head. We place our transmucosal. We place bone all the way up to the transmucosal. We place our prosthetic part with already some flowable composite, and we fill it all the way to the pharyngeal margin. Why I place some flowable composite? Because in this way the flowable composite that I will place around my titanium abutment will stick better. Because if this thing breaks, everything will disappear. You have a problem. Okay? So I want to make it as thick as possible. And then what I do is I place composite, freehand. I go against the teeth. Sorry. I go with my flower composite against the teeth. So in this way, I protect the papilla, food impaction, and I make it as thick as possible. Of course, I don't want to touch with antagonists, and I polish in the mouth to the best of my abilities, and leave it there. So I leave it there at least 4 to 6 months before I go ahead and finish the case. So this is the periapical X-rays, how it looks like. You can see here. You can see the feeling of the bone and the stability of the implant is 8.5 by 5. So let me show you another one. This is more complex because we have problems we have a recession. Whenever we have a recession, then I have to pull not only the soft tissue but also the bone. So here we use a membrane. So I use a membrane here, so it control the bone. So you can see that you can have difficult cases also on the posterior. You can see the root of 25, big defect. As we are going posteriorly, you can see that we have a problem also on the first bicuspid, which we have to do a root canal. As we are going posteriorly, the 27, 26 doesn't have buccal plate. So it's difficult to manage all of this. Okay? So if we look at the CBCT, you can see that we have a problem on the first bicuspid. As we are going posteriorly, we have a granuloma on the second bicuspid. And then on the first molar, there is no buccal plate on the mesial aspect, something that we have to reconstruct here. There is no bone at all, not even in the mesial, nor in the distal. Okay. So not an easy case. Okay. So we are planning to do the root canal on number 24, and then we will place an implant on the palatal aspect of the molar. We did a membrane on the buccal bone, then soft tissue, then grafting, so, and then we put everything down. So you can see a lot of work. All the bone has been leveled to the multi-unit in this case. We're going to do multi-unit posterior teeth because we have 2 implants. This is what it looks like, you know, after everything has been set. So you can see the provisional restoration and how beautiful the tissue stayed with the grafting of the buccal, and the papilla is very much level. And you can see how much the transmucosal helps to have a different height on the posterior. Then we did, we love Procera. It's a fantastic fit. The single crown on the natural tooth and the splinted crowns on top of the, you have the Omni grip, which can compensate up to 25 degrees on top of the implant. It looks like it's on the sinus, but it's within the bone of the palatal implant. You can see it here. And it's a great way of being able to bypass some problems later on. Where we started, where we finished, where we started, you can see we're able to, even on the posterior with a shallow vestibule, able to increase the volume of tissue and bone. And I think it's something to bear in mind and take into consideration. So you can see canine crown on the first bicuspid, and then 2 splinted implants on 2 implants and papilla. As a summary, try to perform as minimally invasive surgeries as possible. Avoid bone exposure, flapless procedure, automatic extraction, primary stability. Remember, tip of the implant is crucial. Bone packing before and after the implant, if you are guided. Deliver the provisional or final abutment is not as important, but you need to seal the socket, which is important for maintaining the verticality of the soft tissue and horizontality. Provide the provisional restoration from day 1st of your implant treatment. The deeper the implant, the more transmucosal should be used. The tuberosity connective tissue graft represents the key for long-term aesthetics, and splint adjacent teeth to limit movement is always advised. Possible retreatment for the patient, let me know. Okay? So if you have any question, I will be more likely to handle it because I will change totally different topic now. Okay? Any questions?